The first thing to say, really, is in terms of funding, 90% of the global burden of disease is in lower and middle-income countries, but only 10% of the healthcare money is spent on that. Total inequality. Let me give you some other stark facts. 1 billion people lack access to water, clean water. 1.1 billion have inadequate access to it. More than 7.5 million children under the age of 5 die from malnutrition and diarrhea, and a lot of that is caused the fact usually from wars and things like that. Over 780,000 people die from malaria. 22.5 people have acute illness in malaria. So malaria is still fairly prevalent, although some of the other infectious diseases we're getting better at. And there were 24 million people living with AIDS and HIV. And TB, of course, is still rife, 1.7 million a year, and it also occurs in England. We're getting a lot in the East End of London as well. Now, the problem is that as you get a country and you're getting it sorted out, guess what happens? You have a war. You have a conflict, it's usually a personality problem, and the world just falls around them. And if you think about it, that since the Second World War, we've had the major refugee crisis, where over 60 million people have had to abandon their homes and go elsewhere. Now, in that situation, guess who gets the worst? It's the women and the children. If the woman dies in a family, the children will die. And the women in these places where they're displaced are raped, attacked, taken away, used as slaves, and as are indeed the children. So there's a huge gender inequality, and I think we need to raise the status of women around the world. We talked about climate change the first time round, and that, of course, is going to have great problems as well in terms of food and the production of, sorry, just let me go back again. As the climate change gets hotter, it's going to be the countries that are worst affected, the hot countries, the lower income countries, that are going to be affected worse. So we're going to have a problem with food. So as you remember, we had the Millennium Goals Development, which finished at 2000. It had some very good things about women, about maternal health, about education, and so on. We've now got the SDGs, the Sustainable Development Goals, and there are 17 different factors of those, and I think 2 of them will be related to women and children. But obviously education and sanitation and so on is the best of all those. So it is our responsibility to go out and help. Aren't we all lucky to be born where we're born? It's an accident of life that we were born in an area where we have got a lot of things going for us. We've got money, we can be educated, we can do what we like. There are others who are not so fortunate. And I think that's where really I want you all to go. And when you do go on your electives, please make sure it's safe electives and make sure it's sustainable. Get a project and go out and do it so that you can come back with some data which will help. Never go out and say, I'm going to do. Go out and say, what can I do for you? All right, that's the most important thing. Now, I was sitting, 5 years ago, I was sitting having a drink, as one does, with medical students at the Royal Society of Medicine. I happened to be president. And the conversation was going on, and it was all about global health. And I said, let's write a book. And then I said, let's you write a book. And we took off with the International Federation of Medical Students Association, who managed to, with 2 leaders, who then got married, by the way, and had a good effect. But they sourced the people. B. Satya and I set the agenda. And the agenda wasn't about diseases and so on. It was about health economics, about climate change, about environment, about mental health, about women, about children, about maternity, and things you all need to know. Now, I think all of you should get that book. I wanted it at £5, but they've actually, unfortunately, raised it to £20. But you can get a 15% discount. Now, the reason I'm doing this is not because the money's coming into my pocket. It seldom ever does, even with a big book. But this is all going back into a pot to help medical people like you, go on electives and do good work. So I'm just setting the scene. But as I may be talking again, but really I just think that it is our duty to do so. Thank you very much indeed.
So Edgar Allan Poe wrote a book called My Savage Muse, and I think you have a muse that drives you very hard, Dame Parveen. I'm sure there are a few more books to come. So our next speaker, I'm delighted to introduce Ms. Li Yumeng. Yumeng is a fourth-year medical student at Imperial College, and she took part in the first Imperial College Enables or ICE expedition to Nepal, and that was in collaboration with the Community Action Nepal charity. She's also been participating in research at Guangzhou Institute of Respiratory Diseases in China as part of the new Clinical Research and Innovation module within the School of Medicine. And she's organised fundraising events for Raincatcher, a charity focused on supplying clean water to developing countries. So welcome, Yumeng.
Okay. Well, good afternoon, everyone. Thank you all for coming today. So my name is Yumeng Li, and as Professor Barts has already mentioned, I'm currently a fourth-year medical student at Imperial College London. So now, following on from Professor Kumar's brilliant address, I thought I'd just like to tell you a little bit more about my own experiences of going overseas and how I felt I've benefited from it. So I've been very lucky in the fact that I've had the privilege of being sent overseas 3 times now by my university. And it all started when Imperial decided that some of its students should be sent to Nepal to teach at local schools, but also to experience firsthand what healthcare is like in a country that's very much different to how we have it in the UK. And so for 3 weeks, we trekked in 3 different teams through the Himalayan mountain range, collecting health data, as well as delivering some practical hygiene lessons in Nepali schools. So our focus in 2016 was on 3 main projects: dental hygiene, hand washing, and menstrual health. For the dental hygiene and hand washing side of things, we essentially taught Nepali children the appropriate techniques using some of the resources that we made ourselves. It was a really great experience because even though the knowledge that we delivered were quite basic, we actually saw some of the kids practicing these teeth brushing and hand washing techniques after school, and it just felt very, very rewarding. And another one of our teams made contact with a charity called Days for Girls, who very generously donated a lot of sustainable menstrual kits for us to hand out to the Nepali women. And you can see an example of the menstrual kits on the screen. So when these menstrual kits were handed out, word spread very quickly, and women from very far away villages actually trekked miles and miles in order to come and see us and get one of these kits. And so I think it made us feel like that we helped to make a difference in the local community. And I'm sure, as you all probably know already, that menstrual health is not a topic that's very openly discussed within these communities. And so hopefully, perhaps the knowledge that we've passed on to these women when we're out there can be helpful for the future generations of girls too. Now, I have to say, the trip itself was also terrifying because we were the first cohort to ever go out, and we had no idea what to expect. And we went out in the monsoon season, so we had to battle through leeches and landslides, and we wore wet clothes for 3 weeks straight, no showers. Okay, so, conditions weren't always so luxurious, But I think it's made us all a little bit tougher on the inside and also more cohesive as a student community as well at Imperial. And in fact, 2 years on, most of my team members, including some of the lecturers who were with us on that trip, we still always manage to meet up over Christmas for a small game of Secret Santa. So, we made some good friends. But I think through all that, the thing which struck me the most through my experience in Nepal was how privileged I am. How privileged I am to be educated and to have easy access to healthcare. And I say that because this was one of the photos that I took in Nepal. Now, in Nepal, I think, looking back, privilege is when kids who are just as bright as our younger brothers and sisters will never have as good an education because of poverty. And privilege is when, if I felt ill right now, I could take my pick and probably stroll to the nearest hospital within, 5 minutes? Whereas Nepali people may have to trek a day and night to the nearest health post. And so I guess through all that, I felt like that in my future career as a doctor, I hope that I will be able to remind myself of the privilege that I felt during my experience and use it to help more people, and especially the people who haven't had access to the same privileges that I've had just because of where I grew up. And now, I think the last slide I want to show you today is this post by the Days for Girls charity in Nepal. So this post was posted this summer when some of our students were sent out again over there and actually carried on some of the projects that we initiated before. And I think it just goes to show that even though we knew practically nothing when we went over there, that we managed to do at least a small amount of good in the community. And hopefully, sort of like the small flame that we ignited 2 years ago had grown more into a sustainable fire that perhaps and hopefully will go on to burn on for many years to come. Okay. Thank you very much.
Thank you, Yumeng. I think you addressed one of the key issues about sustainability, and perhaps we'll explore that a bit more later. So our next speaker, I was introduced as our very own Dean. This is our very own Assistant Dean for Year 5, our very own Associate Professor Tam Kam Ying. Now, Kam Ying, apart from being Assistant Dean Year 5, she is Education Director and a Senior Consultant at the Emergency Department of Tan Tock Seng Hospital, which indeed is only a couple of minutes away. If you go to level 5, there's a bridge which will take you directly there. Outside of Singapore, Kam Ying has contributed to the clinical and educational capacity building project for emergency medical services in Malang, Indonesia. And she continues to lead the capacity building project for 2 rural districts in Sichuan, China. And she's also been an absolute stalwart of our overseas community involvement projects, leading teams of our students. So please welcome Kam Ying.
Good afternoon, ladies and gentlemen. Good afternoon, boss. I start with this graph to remind all of us that for the students we have in Lee Kong Chian School of Medicine, they're born in the latter half of the 90s. The GDP for Singapore, as a surrogate of the wealth of this nation, was between 22 to 26,000 US dollars in those years. The students that we are sending out on all the overseas projects have been born into a nation and have grown up in this 20 years as kids of first world. This is a safe secure, sanitized, sane, structured, what I call the 5 S's of Singapore. I'm always very mindful that every trip that they take, we are sending a first world kid out to a third world community. And I want to start with this because this is the famous Stacy diagram. Singapore is on this side of the diagram. Every day, the decisions that we make, that we ask of our students to think through, the mental models that we build for them, that we build in them, the way we take them through the Student Welfare Committee, where we ask them to present every aspect of their project, budget, safety, liaison, and da-da-da-da-da. There is a lot of agreement, there's a lot of certainty. And sometimes our students run the danger of bringing this kind of first world mentality into a world out there that does not operate in the same zone. So this is Singapore. Decisions most of the time are rational, transparent, pretty linear. And so when they have presented very well to the Student Welfare Committee and we say, okay, you can go, they sometimes will bring this mentality of straightforward accounting, of linear thinking into what I call the zone of complexity and the edge of chaos. For a lot of us who have worked in the Overseas Committee, it is not just complicated, it's actually complex. So I want to use this story to share the difference between complicated and complex. So in Tan Tock Seng Hospital, if a 65-year-old woman presents kind of late with her cancer of the breast, then we need to plan for her adjuvant chemotherapy. That means the chemotherapy that must take place before the surgery, and then rest her for a period of time so that the wound wouldn't break down after the chemotherapy. And if she happens to have atrial fibrillation and also warfarin, then we have to have a plan to retreat the warfarin, and that means consultation with the anesthetist and the cardiologist, get her off the warfarin, make sure she doesn't clot her blood, and then get her through to the surgery, then restart the warfarin and make sure she heals, and then so this is complicated, several layers of difficulty. And if along the way the surgical resident messes up, like the schedule wasn't done properly, the surgeon will be furious. The anesthetist will roll eyeballs, and the cardiologist will probably say, thank God you're not my resident. But things will get done, and the woman will get her treatment, and life goes on. So this story that I have to tell is also another lady in an overseas community who has breast cancer. She's only 40 years old. Her breast cancer was quite straightforward, and surgery would do very well. So during that ward round, where the student was with the trainee and the consultant actually told the lady, you shouldn't be doing surgery here. So of course, the medical student coming from Singapore was kind of surprised. And when the woman asked a little bit more in her language, it just translated into the consultant telling her, you shouldn't be doing a surgery here. And the consultant walked out. So the student went after the trainee and asked, why didn't the consultant offer surgery? So the trainee looked at the Singapore student and said, the consultant is on his way to lunch. At 2 o'clock, he'll be back home where he runs his private surgery. This patient will be discharged later on, and I will hand my consultant's card to this lady so that after leaving this hospital, she will go to the surgery and meet the surgeon in his private practice. The student says, this doesn't sound right. The trainee replies, but that's the way things are done. And the student asks, what if she doesn't have money? The reply is, the family will borrow or sell land to get the money and get the surgery done. That is complexity. And our students actually have no idea what complexity is until they're out there. So to navigate, and I think this is part of the briefing that we should build for all our students going overseas. Number one, they should always have an expectation of unpredictability. Sometimes it's weather, like rain has experienced, okay? Sometimes it's just straightforward factors way beyond our imagination. There needs to be built into every team this conscious effort of the individual and the collective sense-making and reflection in the trip, in addition to coming back as well. And I think most importantly, the ability to link up and work with good local leaders, healthcare professionals who really want to do the right thing for the community. That's important because this cultural bridging cannot be done without that kind of help. The next best surrogate would be faculty members going with our students. If not faculty members, what I call associates. And one of my staff in Tan Tock Seng comes from the Philippines. She has got very good links back to her university, and each of the healthcare university adopts a community in the Philippines. So I consider that a very good associate bringing our students overseas as well. I am quite ambivalent about NGO. That's because I've met good ones. I've also met my fair share of the not so good ones. And so when our students come to me and ask me, is it okay, how do we go about taking consent from the people in the village in order to collect their health data and share? I found that difficulty arises partly because it's the NGO who wants those data. And that takes on a totally different discussion altogether. So therefore, what works for our students are navigational tools like this. Be prepared for the unpredictable things. Be humble. Come together to talk, to make sense and reflect. And most importantly, work with good local partners who really want to do the right things. What doesn't work is to carry the Singapore mentality and the way we do things into those communities and be really inflexible. Thank you very much.
Thank you, Kam-Ying. I think emphasise the importance of briefing, supervision and debriefing, or the value that can bring. So now our next speaker is Mr. Paras Bajaj, who is our very own LKCMedicine medical student. He's in his second year here, and he's currently LKCMedicine Med Society Overseas Community Involvement Project, or OSIP, head. And that means he's in charge of the 6 OSIPs that operate out of LKCMedicine. Last July, he spent 10 days working on Project Sakya in Sri Lanka, where his team targeted the rising incidence of chronic kidney disease of unknown etiology. They organised a healthcare fair. I won't go on because you might be going to tell us about this. So I will merely say that Paras will talk about the LKCMedicine OSIP, the journey thus far. Thanks.
Mic test. Hi, good afternoon one and all. My name is Paras and I'm a second year medical student at LKCMedicine. And today I'll be covering just 3 main things. Just a brief introduction to the OSIPs in Lee Kong Chian School of Medicine, some of the limitations they face and some of the measures we are putting in place to maximize the potential of these OSIPs. And last but not least, my own personal experience in Sri Lanka, in which I'll just run through a brief cost-benefit analysis. So as you can see in this map here, our OSIPs range in different countries in Asia, and they focus on small communities and remote areas where typically healthcare is inaccessible. So our projects have 3 main aims, as you can see here. The first, of course, is to collect data. Using this data, some interventions are drafted, the interventions are implemented, and a long term, there's a monitoring of these interventions. So let me just give an example. For example, OSIP X goes to Sri Lanka. They set up, they find that there's hypertension prevalent in that community. And then they deliver a health promotion and health education program through many years. And then, of course, these impacts are monitored and the project is modified accordingly. This is a short summary of what our OSIPs do. So here are just some limitations that these projects face. And because these projects go to different countries, they function as separate entities, almost like separate student bodies. So what I'm trying to do this year, as in my capacity, is trying to make them collaborate. And what I mean by that is trying to get them to share their experiences and their interventions and how they draft things. For instance, one of our projects that went to Indonesia, Batam, it's known as Project Daya, they're using a geo-tagging system to tag every household that they visit. Because in these villages, the infrastructure is not very organized. So in order to ensure continuity, when these OSIPs go year on year to these projects, they go to the same location using the technology. And now this is being adopted by some other OSIPs in LKC as well. So just one brief example of how collaboration can benefit and maximize the impact of these OSIPs. And secondly, also to make and formalize the monitoring of the project outcomes that these OSIPs have. And this will allow the brief essence of OSIPs to be preserved throughout the years and for people to monitor and then improve the OSIPs as they progress through their education. So this is just my personal experience in Sri Lanka. So what we did in Sri Lanka was to implement a health fair for patients undergoing chronic kidney disease of unknown etiology. And I found that to be particularly useful because many of the villages there are not aware of many important things. For example, they thought that distilled water is unhealthy compared to groundwater because they thought that it loses the minerals, etc. And who knows, that may have precipitated the chronic kidney disease in those villages. So I feel that personally we did make an impact. And not only that, we took it one step further. We did a health promotion basis in which we got the community to come up with the ground up initiative of community discussion. So and this targeted specifically patients and also their families who may be suffering from mental health issues, as referenced from their general healthcare questionnaire there. So definitely I feel that the communities benefit. But yes, as other panelists have also mentioned, there are limitations to this. These approaches may not necessarily work in these communities, and we must be mindful to respect and understand what the communities want rather than what we can offer, so we can tailor it to them. And personally, I can vouch for the benefits it brings to the students because it is really an eye-opening experience to see healthcare being delivered in an overseas setting in a third world country. It is entirely different from Singapore. And not only that, it has also inspired me to be where I am right now, to maximize these impacts and also to look at all these OSIPs in a macro scale so that I can benefit more than just one community. Thank you.
Thank you, Paris. I think the importance of being connected and having some continuity came through there rather than just a random approach. I think also I could see from one of your slides that the benefit to the students of the bonding and camaraderie that occurs through these trips, and I think you mentioned that also. Now, our next speaker is Professor Helen Ward. Helen is Professor of Public Health in the Department of Infectious Disease Epidemiology at Imperial, and she's a consultant in public health at Imperial College Healthcare NHS Trust. She's Director of Education in the School of Public Health and directs the Imperial Patient Experience Research Centre, leading on patient and public involvement and engagement for the Imperial Biomedical Research Centre and the college. Now, Helen's going to take a slightly different tack here, I believe, and talk about the local communities. So please welcome Professor Helen Ward.
Thanks very much. And again, thank you for inviting me to talk about this. And I was interested when I was asked to talk about this. I thought, well, it's not something that I've been particularly involved in. I don't organise electives. It's not something that I've been doing at Imperial. However, about 10, maybe more years ago, time flies these days, I was approached, along with other people at Imperial, by medical students, by the medicine group, in fact, the activist medical students who are interested in global health. And we were asked to do more global health teaching in the curriculum, courses. They wanted a 4-week summer school, and my initial response was, 4 weeks in August? You've got to be joking. You know, it's the only time we don't teach, please. But anyway, we did organise a short course, and that led in turn to an integrated BSc in global health. And a lot of those students wanted to do more in global health, either as a career, looking to their future career, but particularly wanted more overseas experiences. And probably one of the things that I have done most around that is to try and stop that being the focus of our global health teaching. Not that I'm against people having experiences, and I think we've heard quite what an advantage it can be for students to get those experiences of different settings, different health problems, and the general experiences that they can then learn from and bring back. There's two reasons why I'm a little cautious about these, and the first relates to the overall title of this session, which is Who Benefits? It's great for the medical students to benefit. It's great for the medical school to benefit from the experiences they have. And it may also be great for some of the communities that are reached. But you have to understand it in a broader context. There is a long history of colonialism taken forward by doctors, church people, all kinds of people going to do good in other communities. And actually, the net result might have been some good, but a lot of harm. So we always have to think, in what context are people going and what's the net benefit? And I think, as a global health teacher, what I want to emphasize is, yes, do have these experiences, but understand your role in the world. And I thought it was very particularly useful what Kumar was saying about first world students going to a third world setting. With privileged students going to places they would not otherwise go. Reflect on that and think about what else you can do to try and minimize the differences, not just by going and doing good, but thinking how can you help empower some of those communities to actually get more resources and better health care and a more sustainable outcome. But the second reason that I'm cautious about overseas experiences is because if you really want to understand global health, and what the students were asking for in terms of global health was to understand less privileged communities. You do not have to go overseas to find less privileged communities. Parveen will know very well that if you go from where Imperial is based at South Kensington, and you go however many stops along the tube line towards East London, for every stop you lose a year of life expectancy. Life expectancy varies by 18 years between the most and the least privileged parts of the UK. That's 18 years less healthy life expectancy if you're born into a poor community. You can go and work with local communities. Now, those people do come into health settings when you're at Imperial or when you're here working. You do see people from all kinds of backgrounds, but you can also go out and understand them in communities locally. So I think global health, the slogan of, local is global, global is local, I think you can do that kind of work, and you can focus that on something where you can do it even more sustainably. There are refugees, speaking from my own experience, refugees in London who have very poor access to healthcare, need support, and you can set up programs for medical students and others to support those people getting better access to healthcare. You can also work with families where there's children living in poverty. There are millions of children living in poverty in the UK, very few of whom end up in medical school. So it's within your own community, there is still this difference. And there are communities who have problems with FGM and access to services, and talking about that. There is also the menstrual problem is not just a problem overseas. There are girls who cannot go to school in the UK because they do not have the money to have menstrual support. So I think I'm just trying to put this in a broader context to say you can get these experiences, you can actually do some good in your local communities as well. But I want to finish by saying, on that note, I still do think it's important, but what I also think is important that as a community of health professionals involved in training, we look at our training. It is a lot more use, to be fair, to communities if experienced clinicians go out, live and work in communities that have very poor healthcare. But our systems at the moment discourage that. If you take time out of your medical postgraduate medical training, it's not recognised. often, and there are many, many disadvantages to your career for doing that. There's many advantages in terms of experience. So we need to look at the whole medical training from medical students right through to consultant and beyond, how we can actually have better relationships where we're giving more back and actually supporting development, medical training and so on in low and middle income countries. So, I applaud the kind of things that you've been talking about. They sound like fantastic experiences, opportunities, and I'm really pleased to hear about the sustainable approach of these overseas community involvement placements. So thank you for inviting me, and let's have a good discussion.
Thank you, Helen. I think that's very thought-provoking, and you presented it in a beautifully balanced way. So I'm going to now join the panel and invite questions or points of discussion anyone would like to raise. Let me start then, while everybody's thinking, by perhaps asking what people would consider as best practice. I guess we've had some examples of that, but perhaps I could ask each of the panel members to make one point about what they consider to be best practice in an overseas experience. Parveen, would you like to start?
No, thank you very much. It's been very nice listening to everybody and what they've done. I think, James, you make a very good point. One of the problems is what you don't want to do is to go out and upset the local working, because I think if you do that and then withdraw it, you then leave a bit of a gap. Secondly, and we're talking about medical students, never go out and do something that you're not able to do, which certainly the GMC would not allow you to do here. So if you can't do something, say you cannot do it or you haven't been trained for it. Thirdly, God, I'm going to go many, many numbers. Tell me when I stop at 100. Thirdly, I think it's the best thing you can possibly do, because I think what we've heard, wonderful stories from both Rain and Faris, that you see things that you'll never see before, you never encountered. It makes you feel that you are able to change in yourself to adapt to what's going on, but also see what they need. But then always do it with them and discuss it with them. And I think the one of the things that I do feel very strongly about, it's no good just going out and doing one thing. You need to perhaps organize a system or a place where you can continually send medical students to, so that they can continue the work. And one of the things that I used to do was a trustee of THET, Tropical Health and Education Trust. And what they do is a charity just set up about 35 years ago, where you form partnerships. And for example, the Kings and Somaliland partnership has now gone on for 12, 13 years and is doing incredible well, because you have exchanges with midwives, with laboratory workers, with nurses, obviously with doctors, medical students, and so on. And that way around, you can enter a project and establish that. And we've just had one starting at, which I started with THET again, with Barts and Axum, which is in the north of Ethiopia. And that's been a very slow project because the powers that be said, where's the money? And I said, this is your altruistic arm. And of course, they said, sorry, Parveen, where's the money? The medical students took it on. Absolutely amazing. And I was just so impressed. They took it on. They have online lectures which go out to them. The medical students go out. We taught them how to do PBL, teach PBL. They went out and taught PBL. So they are the ones who have actually been taking on, going there, constantly doing it. So I think you need to do a partnership, you need to have sustainability, but my goodness me, don't you learn a lot? You learn about cultures, how different people live. I've already heard how, people can be so poor. I think you showed that lovely picture. You have to adapt to what they've got and do it for them. So thank you, I hope that's said something.
Okay, well, did you want to? I'll invite people to add. I'm not going to force everybody to add to that, but would anyone like to add to that about best practice? because Jan's ready with a question. So perhaps we'll go to Jan and we can always come back to that.
I'm not sure it's a question. I'm actually following up a little bit on both the input from the presentations, but more importantly from what Parveen was saying. I think the long-term aspect is really important. And the long-term aspect starts with a partnership, yes. I'm talking about now my experience from Karolinska Institutet. We had partnerships for over 20 years with Hanoi Medical University, with Makerere University in Uganda. We had staff present there all the time. We had students going out all the time. More importantly, we had capacity building there. So we developed PhD programs, sandwich PhD programs, to build up capacity locally and make sure they were doing the work locally and not going to Stockholm and leaving their community. So capacity building, long-term and local presence is really, really important. Understanding the culture is really important. And this last one, I think we've had a number of other projects which have gone badly because students have gone out without sufficient knowledge of the culture and how to act in that community. And it can do damage, just as you're saying. So I think if you're going to do this, which you should do, because it is incredibly valuable for the students, it's a really important aspect of understanding the community, your own community, not only the community out in the world, but to be able to do it, you have to actually get sufficient knowledge and input before going there, and particularly with regard to culture and how to act there and what to expect. And then debriefing afterwards is equally important.
Thanks, Jan. So could I ask Helen make a comment?
Yeah, thanks, Jan, for that, because I think I just wanted to comment on that last point. In our Masters in Public Health programme, we've introduced a module, an optional module on anthropology and public health. And it's really interesting that we talk about culture there in that and it's very difficult to teach in a short period of time to teach people with very biomedical backgrounds about anthropology, I have to say, including myself. But one of the most important things there is to actually start with people understanding that culture and beliefs are not things that they have, other people have. Culture we all have culture. Culture is about relationships, it's about understandings of the world, and we have those, other people have different ones, some people have the same ones. And it's very important to, in that education, I learn a lot about the students, particularly about people feeling they should be able to go to low-income countries and educate local people about why their beliefs are wrong. And I think you have to really resist that kind of one-sidedness and say, that's why vaccination programs get into trouble. Because you think people are just stupid, if only they knew what was right. Actually, you have to understand those rumours about vaccines are often based on experiences of people coming in and doing bad things to their communities, and therefore they have mistrust for a reason. So I think understanding what culture is and how you can study it, as well as reading about things before you go somewhere, I think is really good advice.
Thanks, Helen. And perhaps thinking about what are we learning from those communities, about relationships, about loyalty, for example. I think this is something that I certainly learnt through working with Aboriginal communities in Australia. That some of their values are things we can learn from. Parveen?
I was just really going to give a quick example following what Helen has said. I was in Liberia between the war and the Ebola epidemic. And the one thing that really got me, I mean, I came back, and Jan, thank you, I don't know where Jan's gone, thank you, Jan, about get debriefed. I came back really very bruised, having seen what I saw. But what I did see and what I did think about was, my whole inside turned over, thinking about that 90% of the women had FGM, female genital mutilation. And I sort of accused the driver who, with this chap with the gun at the back, but the driver was a friend. The chap with the gun was a friend as well. I said, why is it you men do this? And he said, we don't do that. We don't want that. He said, it's the women who want it. And I said, what do you mean the women want it? He said, it's all a matriarchal society. They had it, therefore they will insist that the children have it. And the women's is the only thing the women have of their own. And, the grandmother, there's one woman in the thing. So they go, and there was this girl walking along all naked, covered in chalk, being taken along by women walking along to the next village to have it done. And, obviously there's death and you don't know what else goes on. But having done that, what he said was what we need to do is to give the women something that is their own, and then we can try and stop that. Thank you.
Peter Abrahams.
I'd just like to agree with many of the things that 2 or 3 of you have said in the last 5-10 minutes. But I personally went out and did an elective, in fact, in Borneo. And that so stimulated me that I now, in my later life, have set up a scholarship and an MOU between UNIMAS in Borneo and Warwick University. And what I would like to suggest, it shouldn't be a one-way movement of medical students, it should be a two-way movement. And we've found that what we've now got is a club of students, some who are Borneo students who've come to Warwick, and Warwick students have gone to Borneo, and we make sure that before each student goes in each direction, they are taught by the student that was there the last year, and those students have to send to me a complete debriefing report of what they've gained and what they've learned by being in the different culture. And this interchange of elective students has made an intellective club, an intellectual club, who actually last year, 8 of them all met together in Kuching, and then 6 of them all met together in Warwick, and they're becoming a sort of team. And I know that 2 of them have won the prize for the best student in Borneo and will be future leaders in Borneo. So they will be the people that will change whatever is good or bad, and I'm not making any comment in any direction. And I know that it had an effect on our students, having Borneo students looking at cardiac surgery for the first time and who had not seen certain operations, and they wanted to know things that were different that they could take back to their country. So I would suggest it shouldn't be a one-way thing, Singapore only sending out students to obviously underprivileged areas, but those underprivileged areas, and maybe Singapore can help in the financial side of that, should come back into the Singapore health system. That has a much longer long-term benefit to both communities.
Thanks, Peter, reinforcing comments about continuity, long-term investment and reciprocity. Martin Lupton.
So I have a question. So one of the things that struck me when our students came back from Nepal was a number of them felt very uncomfortable about how much money we'd spent on sending them to a place which could have used the money in a different way. So if we think that these things are of value, how much do you think medical schools should invest in spending to send these kids to poor places?
Okay. Kam Ying, you're in luck.
I'm not sure there is a magic formula to convert, but this is how I think through whenever I lead a team of students and sometimes junior doctors for the projects that I have in China or previously in Malang, Indonesia. The first thing I do, one of the key things I do before we leave is always to set their expectations right. That the Singapore dollar is extremely powerful. What I spend on a coffee bean tea leaf is money for 3 days worth of meals for a whole family. Okay. And that is a reality that we need to have anchored in our heads. Second reality is when we go over there, a certain amount of money has to be spent. Flight, accommodation. And so does it mean we go and stay really rough, not even a hotel, and in order to save money, to share more of the money there? But what is the downside? The downside is physically, most of us are not ready for that kind of rough conditions. And if we're going to go there and suffer in order to save some money, to give some more money to the project, then what is the point of even going? We shouldn't go. We should convert that money to a reasonable NGO or to the local community and just give the money. Why go there? You should only go there when you really have something to contribute, right? And most of the time, it's actually the surgeons who think, and okay, to be fair, they do contribute. And so this issue of the power of the pound in UK and the Sing dollar in an overseas community like this becomes an interesting discussion point. And reminding my team members that it is not about, it cannot just be we spend so much money sending our students or our junior doctors there just for their education. I think it is not a linear relationship. And when they come back, that's the other part that the settling in is again very important. They feel so bad that they go and have a coffee in Coffee Bean and Tea Leaf and get reminded that this is money of 3 days worth of meals for a family. We all have to come back to the cost of living and the reality in Singapore. But what is important is maybe not so much for the students, and I have a point to add to that, but for the doctors who go, to be very mindful that we are there to contribute. And if we have a skill to contribute, we should share it in a meaningful way, contextualized to their needs. So in Singapore, the teams that I bring, the junior doctors, we have pounded into their heads. Hand hygiene is so important. They get very upset when the soap dispenser runs dry. And so they only have water to wash their hands. And then they are told that, you need to go in and assist in the surgery. You can see the look of discomfort. So one of them decided to scrub down because he said that, Dr. Tam, I really cannot imagine that I don't wash my hands, I'm going to assist in the surgery. So I said, then what are you here for? Did you expect them to have soap dispensers all filled up with soap? When soap costs so much. So the next best thing is wash your hands thoroughly with the water supply that they have, and they have iodine. Clean your hands with iodine. Be flexible. So it takes a lot of brainwashing them really on a trip there to move them away, to get them to think that, because we have spent so much money coming here, that we shouldn't use money this way. That dollar value for the education that they learn, I think, is not linear and is still worthwhile. And for the students, this is coming back to James's first question, what's best practice? I would tell all the medical students, all those things that you think are nurses' work, like health education, health promotion, go learn them. Before you have a license and you cannot prescribe treatment or even give sensible management plans, the most important thing you can influence is actually good health practices, starting with each individual that you come into contact with. You can influence, and that's, I think, good practice.
Thanks, Kaming. Now, I'm going to ask Yu Meng to add something to that because she is a student from Imperial who went on one of those trips, or several.
Indeed. Okay, so I'd just like to start by saying, obviously, as a student who has been sent overseas by my university, I am extremely grateful for the amount of resources that my university has invested in me. However, like Mr. Lapta has mentioned, actually when we came back from our trip to Nepal, a lot of us did actually question whether like what kind of benefits it actually brought to both us and the communities over there, and whether it's worth it. Because we thought, it is a lot of money to be sending, say, 40 students over there, overseas, paying for flights, accommodation, etc. And whether, maybe that money could have been spent, just donated over to that country. And, like Professor Ward mentioned, we could have done some more good, perhaps in our own communities in underprivileged areas. Now, would that be a better way to spend the money? And I think this conflict sort of came up, and we sort of reflected on it. And I was talking to one of the professors that I'm doing my research with, and she said to me, if you think of it this way, so the amount of money I used to send you guys over there, with that same amount of money, if I were to buy the exact same amount of teaching hours over here in the UK, I would not be able to buy it. So the amount of experience, the sort of like immersive experience that you've had over there is actually of a lot more value than what we could teach you in the classroom. And I think that's quite an important thing. I mean, it's kind of opened my mind to sort of like, that way of thinking. And I think that in terms of like the sustainability, I think really we shouldn't maybe be focusing on like how much it actually costs to bring us over there, but how we can maximize sort of the benefits that we can get from sending students overseas. So getting us to do more and getting more involved in helping those communities even after we come back from those trips. For example, we're currently, with the ongoing sort of menstrual health side of things like that project, and also fundraising for the communities that we've encountered over there. And I think that's something that's more important to focus on. Yeah. Thank you.
Great, thanks. And Parveen,
Extremely
quick comment?
briefly, I know we're getting short. Martin, what a question. You are so lucky. We spend nothing on sending our students abroad. They all have to earn their own money. I spent ages trying to get grants and things from various people. I write references like mad. We get delivery companies to do it. We have some donations that people have given in the past that can be used towards this, but it's all charity money. And what we gain out of them is they coming back and bringing back practices that they would never have seen. And it goes back into the NHS. Thank you.
Just one moment. I thought Yumeng raised a really interesting point. We allocate, if we think of how much we spend on medical education, and we work it out how much per week we spend, should we be spending that money rewarding the local communities for teaching our students, giving them real life experiences? Okay, now we're going to wrap this up soon. Take one more question, and then I have a question for Bajaj. Don't look worried. It's okay. Yep.
Thank you.
Thanks.
Good afternoon. My name is Tong Li. I'm a year 4 LKCMedicine student. So my question is kind of related to the fact that unlimited resources. But first, thank you very much for your sharing. And I think that my question is, as students and future healthcare professionals, going on such overseas community trips in the future, I think as what many of the speakers have shared, sometimes when we set out to go, we may not have all the answers on how exactly we can best contribute to the community. So in that sense, we keep learning about their preference, their wants, their needs, and we learn along the way, and our goals may also like evolve. So the question is, given that the question is kind of like about exit. So given that we have limited resources, whether in terms of the funds we get from the organizations we represent or work with, or in our personal capacity, so when we go about so from your experience, when we go about doing a project, what advice would you have for volunteers in terms of how we could evaluate the value of continuing our projects? For example, we might realize along the way that we are not really that useful in certain aspects, and we are still very much trying to learn how we can be helpful. So what would be some of the advice you would have in terms of how we can evaluate our usefulness there, and when, could be a time for exit or transitioning to a different kind of help, maybe not by traveling there? Thank you.
So asking how do we measure the outcome? Kaming, you want to
get Paris to start speaking?
Sorry, Paris. Yep. Do you want to try that, Paras? Yeah, yeah.
How can you say
That
no,
might
right?
be easier than my question.
Yes, definitely. Thank you for the question. So when we start off these projects, yes, we may lack the long-term impact because as many of the panelists have mentioned today, we do not have the idea of what the community requires. So definitely there's no perfect 100% solution that what we're going to do is effective. So the first thing to have is an open mind. We need to continuously trial and error to see where we are engaged throughout the years. And I think we are discussing this with Professor Thum as well, that we are trying to implement a model for the OSIPs to monitor their impact in the short, medium, and long term. So it's called the outcome logic model, and this will allow the OSIPs to see where exactly they stand and where exactly they need to proceed. So as you mentioned, that if the focus changes in the center, they can realign their focus in the long run. So for instance, I'll just give a brief example. Let's say community X has hypertension. And the students, they go out and effectively in the long run, we would like to see the lowering of their blood pressures in the data that we collect. So this can be segregated into certain short, medium, and long-term outcomes. The long ones we obviously know, but the short one can be, for example, health promotion programs. And this is where the tricky part comes in, as you mentioned. It may or may not work, which is where the trial and error is important. So using these health promotion and health education, where we get the patients to refer themselves to the nearest healthcare facility, because obviously we, as OSIPs, we cannot be there with these patients 24/7. We cannot be there to observe them taking this therapy. So the first is obviously informing them that they have this issue, which many of them do actually take note of proactively. For example, in Cambodia, when these patients found out that they did have diabetes and hypertension, which they had no knowledge of earlier, they were actually quite worried, and they did seek attention. So coming back to the short-term impact, we want to encourage more people seeking medical attention for the illnesses that they have. Then the OSIPs can then progress into the medium-term impacts. For example, the taking of beta blockers, or the taking of proactive lifestyle to counter the effects of hypertension, for instance. So all this can be done in a structured manner. And obviously, there's no 100% solution, as I mentioned. It has to be a continuous trial and error. And there has to be this concept of micro speed, macro patience. So while we may get impatient to see that our results, our impact, our inputs are not showing the outputs that we want, we need to deploy the macro patience in the long run, and yet continuously try with maximum speed in the short run. Yeah, thank you.
Great answer, thanks, Paras. So I think that emphasises also the importance of continuity on building on the work that others have done before, and it is important to try and get some measure of what benefit there could be to the local communities. But I think it's also important that we get some idea of what benefit there's been to our students, how the students have benefited, and sharing of experiences. And I think that's what you're doing in trying to link up the different OSIP programs. So unfortunately, we have to round up this session, which...
Can I give them some homework? One sentence.
Okay.
Right.
How can I say no?
I am going to give you some homework. Right, so when you get home today, please can you look up Google and look up the word JUGAARD, Jugard, which is making the best out of adversity. Please, that's your homework. Thank you.
Okay, I will certainly do that. So, so I think, as advertised, this has been a very stimulating, exciting session. Great way to round off what's been a fabulous conference. And now we're coming to the closing ceremony. And so our students are going to introduce that final session, and we can all take our seats back in the audience. Please thank the speakers.